Aside from non-melanoma skin cancers, prostate cancer is the most common cancer diagnosed for men in the United States and the second leading cause of cancer death for them. Its varying degrees of aggressiveness, along with high incidence to mortality ratio, provides significant challenges for both patients and the medical community. However, the treatment landscape of prostate cancer and its metastatic form is rapidly evolving. Most recently, trials with PARP inhibitors as a monotherapy or as in combination with androgen receptor pathway inhibitors has a great promise in improving their outcomes.
Welcome to the Baptist Health Doc to Doc podcast, a conversation for physicians by physicians, providing insight on the latest in medical practice, research, technology, and innovation in healthcare on the Doc to Doc podcast.
Hello, I'm Dr. Rohan Garje, a medical oncologist and chief of genitourinary medical oncology. I specialize in the treatment of prostate, kidney, bladder, testicular, and penile cancers at Miami Cancer Institute, part of Baptist Health, South Florida. And joining me is today Dr. Adil Kaiser, a board-certified radiation oncologist specializing in the treatment of genitourinary and gastrointestinal cancers at Miami Cancer Institute, part of Baptist Health, South Florida.
Thank you for the kind introduction and for having me here. I thought it would be interesting to start off this discussion by by a discussion of some of the more recent advances in terms of screening guidelines.
Yes. All right. Screening for prostate cancer has always been a challenge in the sense, the various guidelines, either from American Cancer Society, AUA, ESMO, and also, United States Task Force, and also PCF. So there are several measures, several organizations, but the goal is, informed discussion in the sense, shared decision-making. A physician and a patient sit together and talk about what are their risks, what is the family risk, what are the symptoms, and then collectively make a decision whether screening for prostate cancer is an option for them and how it is done and what are the risks and benefits associated with it. But I think the key for practicing clinicians is to make sure identify their high-risk patients, especially patients with family history of prostate cancer, patients from African American origin, because it has been shown that people with high risk, with family history, or based on their ethnicity, there is a high risk of them to have not only prostate cancer, but they present with higher risk disease, which can have implications on their life expectancy. So, according to various guidelines, for men with average risk, which is at age 50, we would recommend them to have prostate cancer screening in the form of PSA check and optional rectal exam. Now, having said that, for African American men, a lot of data has now come up saying that it is better to start early if possible. So some of the screening guidelines are actually talking about starting screening at age 45. Now, in addition, if men have family history, especially with a mutation called BRCA mutation, it's very important to screen them very early, even at age 40. That helps identify men at an earlier stage so that we can identify cancer earlier and take care of it at a localized form. And then the next big important aspect is disparities. As you know, patients who have access to care, there is always an option, but the big level of awareness is to bring up how to identify people who don't have access, disparities due to various reasons, not just their access to medical care, financial situation, economic situation, and then based on various other aspects of their current health situation. I think it's important for us as a community to raise awareness about prostate cancer screening. And the goal would be to identify people who are at high risk for cancer, be identified and screened with this process.
So, I think that was a great summary of some of the more recent screening recommendations. And it just raises and highlights the importance of doing a good, solid family history, at the time of the initial consultation. Because, again, if you have a family history of breast cancer and then you discover, yes, that breast cancer was associated with the BRCA1 or 2 mutation, then obviously those are patients that you want to flag and start screening at an earlier time point. So very important for urologists and PCPs to keep that data in mind.
Yes, you're right. All right. So moving forward, actually, so we now, beyond screening, we're also looking at newer imaging tools and techniques. Dr. Kaiser, can you talk about the role of MRI in prostate cancer, as well as the new PSMA imagings, which we widely use now?
Right. So MRI has been a tremendous tool, and I would say, very important advance in terms of diagnosing cancers, and particularly in diagnosing higher grade tumors. So a lot of data, especially out of NIH and Dr. Pinto's group, showed initially that if patients had a biopsy and a standard, let's say 12-core biopsy for a elevated PSA, and they were discovered to have prostate cancer, that if you took those patients, did an MRI, up to 1/3 of those patients, based on the data, could be upgraded on confirmatory biopsy. In other words, a biopsy that's done after the initial biopsy, but targeted to high-grade, high PIRAD score lesions that are seen on the diagnostic study. So that became a real game changer in the last several years in terms of how we diagnose prostate cancers, to the point that now a lot of guidelines suggest that you should actually do the MRI even before you do the biopsy, so that the initial biopsy itself is MR guided, and therefore that you do the standard 12 cores. And if you see any high grade lesions within the prostate, that those should be sampled in addition to the 12 cores. So as a consequence of that, I think we have much better patient stratification. We, again, are very good on the MRI of identifying these higher grade lesions. MRI is not so good for lower grade lesions. It's really separating the high grade tumors. And of course, that's important to us because we really are slowly, as a field, dividing the patients more into kind of low grade tumors that are indolent, that can be watched, let's say, with active surveillance, versus the more higher grade tumors that we need to be more aggressive with. So I think MRI has been a great tool to help with that decision making. And then in terms of the PSMA testing, this has been also another game changer. I think in particular, I wanted to highlight the recurrence setting. Before the advent of PSMA testing, we had other modalities too that we explored, like Oxamen, et cetera. But none of those actually gave really high specificity and sensitivity in terms of identifying recurrent tumors. PSMA, of course, has been a real game changer. At Baptist Health South Florida, particularly at Miami Cancer Institute, we've instituted PSMA PET-CT testing for patients who qualify, in other words, recurrent disease or high-grade disease de novo. And with that, we've noticed that we can much better identify recurrent lesions that we previously would not. So we see many cases where standard CT imaging just shows, let's say, a small lymph node, sub-centimeter. But when you layer on the PSMA PET component, we see that it's positive. And initially, we were doing a lot of biopsies to confirm this. And we found that there was such a high rate of concordance that they were real when they were PSMA avid. And in addition, the data also suggested that the specificity was so high that now we've kind of moved away from biopsying all of the PSMA avid lesions. We almost assume that they're all negative. I'm sorry, that they're all positive. However, there are notable false positives in some cases, particularly in osseous areas like the ribs. And I know we've shared some cases like those. Perhaps you can comment on that point.
Yes. PSMA imaging, as you said, has been game changer. I think anyone with biochemical relapse, relapse setting, I think it has really impacted their treatment outcomes. And as you rightly pointed out, based on our general assessment of these scenarios, most common expectation is the recurrence happens mostly in the tumor bed or in the pelvic region. And then, but we have to be very mindful of some false positive reasons, as we rightly discussed, which is our common discussion point in our tumor board, specifically distant findings, in the setting of low PSA. We do see false positive changes in the ribs, which has been quite a challenge. And there is a lot of data, for patients who have only isolated rib findings, we have to be very cognizant about benign bone lesions, because sometimes occasionally fractures, fibrous tissue or bony islands can look PSMA positive. They may not be metastatic disease. So it's very important, if you have an old scan to compare, go with a history. And also, if the PSA is very low, be very careful in coining some terms as metastatic, because this may really change the treatment approach. And in very exceptional scenarios, I think when the clinical picture doesn't match with what you think the scan is showing, try to get a biopsy if it's feasible. I would like to share an example. We had a patient with diffusely positive lumbar spine lesion, actually, and this didn't match the clinical picture. So we went ahead and did a biopsy, and it actually, in fact, turned out to be a hemangioma. And there is now literature which shows that hemangiomas do sometimes have PSMA positivity. And additionally, some other cancers, for example, again, this is not common, but, kidney cancer or myeloma can also be randomly PSMA positive. So I think this is a valuable tool, PSA imaging. It has definitely changed the treatment approach. But when the radiological findings don't match your clinical expectation, where things are out of proportion to what you would expect, I think it's very important to do biopsies or definitely have a multidisciplinary conversation. That way we make sure we do the best care for our patients.
So Dr. Gargi, just to kind of expand on that point a little bit, do you, in your practice now, for let's say a de novo high-risk patient, do you go straight to the PSMA PET-CT for staging, or do you still do the classical bone scan plus contrast CT first?
Yeah. I know it's, again, it's a variable approach. So if it is clearly a high-risk disease, where the Gleason score is high and the PSA is more than 20, now I have been using PSMA PET as my standard baseline scan, because it's one scan which covers everything and helps avoid, additional scans. Now, I think the practice is variable. The guidelines are also a little bit broad here. Some prefer to do both, because the biggest challenge is follow-up scans, because most of the data right now for follow-up is based on CT scan and bone scans. PSMA scan as a follow-up scan for reassessment, the utility is still being questioned, or we still don't have data. So it creates a lot of, ambiguous zones for us how to interpret the data. When I start with PSMA PET, and if it gives me all the information I need, we just stick with that. But in select patients, we do obtain bone scan and CT scans.
Exactly. And I've kind of been doing the same thing. If I see a patient with very high risk features, we go straight to the PET-CT, PSMA PET-CT to be specific. And occasionally, though, insurance will deny it. And in that case, they want to see a CT scan first. So we're kind of obligated to do the standard staging and then move to PSMA PET if needed and indicated. But definitely, it's kind of become more and more the default.
Yes.
And in the recurrent scenario, I think it's important, as you said, to understand that there's obviously a correlation with the amount of PSA that you're seeing and the probability that you'll actually see something on the PSMA PET scan. So at least at Miami Cancer Institute, we've agreed in general as a default to have a cutoff of 0.2 nanograms per milliliter in terms of the minimum PSA before you would pull the trigger and order a PSMA PET scan in the recurrent setting.
I'm assuming 0.2 for patients who had surgery and recurrence. Maybe for patients who had radiation and we are looking at recurrence, maybe we could have a higher threshold of PSA for obtaining the PSMA PET scans.
Right. So the radiation failure guidelines still are utilizing the Phoenix definition, which is the nadir plus 2. So again, because it's a gray area, because the guidelines are not really set yet, what we've been doing is if we see a high velocity in terms of the PSA growth, and yet it's not quite reached the 2.0 landmark, I might still pull the trigger and order a PSMA PET-CT, in that patient. But typically, if it's very slow velocity, again, looking at all these other clinical factors, then we may not. Plus, you also have to rule out benign causes of PSA increases, prostatitis, etc., because the prostate is still present post-radiation. So definitely not unfortunately, clear-cut guidelines. But I think in the post-op cases, we have a little bit more understanding. 0.2 is the generally considered the acceptable PSA cutoff for surgical failure, at least biochemical surgical failure. And so we thought that was also reasonable to do the PSMA PET scan at that level.
I agree. And I think it's important for, physicians who are focused on prostate cancer care to really, understand these fine nuances about when to obtain these scans and what are the different indications, what are the potential false positives, to make sure we are all aware of about these changes, and that way we can give our patients the best care they can.
Before we move away from this topic, I had one other question for you. Specifically in the recurrence setting, one of the challenges with many of the PSMA PET scans is that there's quite a bit of uptake in the renal system, because that's the way the molecule is cleared. So you actually have quite a bit of uptake in the bladder, and unfortunately, this can obscure recurrences at the anastomotic location. So what are your thoughts on this? Obviously, there's different vendors that have come up with potential alternative ligands that can be used instead of the classic one that's currently employed.
I think you have a very important question, because when we are looking at biochemical relapse, the biggest concern is it's at the prostate bed, including around the bladder neck area. And all these dyes, we have 4 different agents which we use for PSMA PET scan. They are all excreted through urinary system. I think the biggest challenge here is timing the imaging, so that timing to the point where the activity in the bladder with the agent is less, so that we do that. Or there are some protocols where they use diuretics before they image the patient, so that the patient's void and they do it. And then there are some newer imaging technologies. One of the commercial vendor called post-luma imaging technique that has reportedly less bladder activity. So, a fractional benefit over other scans, where it can have a better ability to identify bladder neck recurrences with limited noise from the excretion of the dye in the bladder. So I think it's, again, as you rightly brought out, it's very important for us to be very much involved with our radiation team, the nuclear medicine colleagues, where we communicate with them that we are very focused on bladder neck or tumor bed recurrence, and tune the imaging so that we can focus on bladder neck more appropriately. Otherwise, if it doesn't give us the information, then it becomes challenging for us to plan a treatment based on radiation or anything else.
Yeah, the one thing I would add to that is, as Dr. Gargi has pointed out, there's nuances to this, and this is still being worked out. So at least in our practice for patients with post-op biochemical relapse, we have, in addition to the PSMA PET, gotten MRIs. And I can tell you, just literally yesterday, I had a patient where the PSMA PET scan was fine. It didn't really show anything at the anastomotic bed. But when we did an MRI, it actually showed a 2-centimeter area of recurrence, highly correlative and consistent with local recurrence. And based on that patient's PSA level, that was not surprising. So I think it's important to, not just do a PET scan in a post-op patient, and you should also do some pelvic imaging, particularly MRI, I think is the one that we favor. That's
interesting. I think it's a good point to segue into, radiation therapy approaches, what we have at Miami Cancer Institute. Dr. Kaiser, can you talk about MRI LNAC options, proton versus photon therapy, which is a common question we get, though as a medical oncologist, I cannot answer, but every patient has that question for me. So maybe can you share your thoughts on different tools and techniques used in radiation therapy?
Sure. I'd be happy to do that. Since we were just talking about postoperative cases, I thought I would start with that. So, again, it's very important to identify if a patient has nodal recurrence or gross recurrence at the anastomotic bed, because that affects our radiation dose. So having that proper staging is key, just to make sure that you're adequately treating the patient. So typically, if you look at the postoperative trials, they're treating mostly to a dose of around 66 gray to the postoperative bed. But if you have gross recurrence, we are typically dose escalating those cases just to the anastomotic bed to a dose anywhere between 70 to 74 gray. You don't really, of course, need to do that if there's no evidence on imaging of a gross tumor recurrence. There was actually a paper that examined 64.8 gray versus 70 gray and found that there was no added benefit going to 70 gray, even if there was a clinically positive margin. And so all you're doing if you treat to 70 gray is really enhancing the toxicity profile. So our practice in general has been to treat, somewhere in that 66, and in rare cases, if we're very suspicious, maybe to the 70 gray dose. Now, in terms of the nodal disease, it's the same issue. Since before the advent of PSMA PET scans, we weren't really picking up a lot of these smaller nodal recurrences. Most of those were just treated to a dose of, anywhere of 45 to 50 gray on most of the clinical studies. And that's why, when a patient sees me for recurrence after surgery, the general number we quote in terms of success based on the GETUC studies is in the range of about 2/3. So if you do a combination of hormonal therapy and radiation, you have a 2/3 success rate. But what I tell these patients is now with PSMA testing, we are more confident that we are probably ruling out distant recurrences and we're dose escalating the nodal recurrences and we anticipate a better success rate. So that's the post-op setting. Now for de novo setting, you pointed out, for intact prostate, if they select radiation, of course, surgery, and there's other options available to them too. But if they select radiation, they also have the additional issue of selecting which radiation modality would be best. And of course, as you highlighted, there's several. We have MRI, guided radiation therapy at our facility. We're blessed also to have proton therapy, more specifically pencil beam scanning proton therapy, so intensity modulated. In addition, we also have standard true beam technology, which we also use for SBRT. So all of these platforms are here. And what we try to do is, of course, pick and choose and personalize the care to what would be best for the patient. Now, in terms of just protons versus photons, again, we don't have a phase 3 trial completed just yet to say that protons are superior or maybe the results are equivalent. But based on just dosimetric data, we know that if you do proton therapy, because again, with protons, it's you have actual mass to the radiation beam, we can control where it stops. It doesn't just go through the patient like a standard photon beam would. And because there's no exit dose, we are able to minimize dose to structures like the bladder, the rectum. The people who would be naysayers to proton therapy would say, well, that's true, but really what you're doing is you're reducing the low dose area of radiation therapy in the pelvis, but the high dose area of radiation to the rectum and the bladder, meaning the part of the rectum and bladder that is adjacent to the prostate, are still going to be similar. And that is actually a fair criticism. You could argue, until we have phase 3 data available, that most of the serious complications are in the high dose areas, which would not be that different. However, we do have data already available based on IMRT that the amount, the volume of the bladder, for example, that gets irradiated highly correlates with future toxicity in terms of especially simple things like urinary frequency. And that makes sense because the more radiation exposure there is to the bladder, the more chance of fibrosis. And so we generally favor doing proton therapy as a result to minimize these risks in the majority of, I think, our intact patients. And that's done with standard fractionation, which is usually in our group 39 sessions at 2 gray per day, or with hypofractionation using the Cleveland Clinic-based model. But when you go down to MR-Linac, the last topic that I wanted to highlight, or SBRT, we've typically used the standard doses. So that's a dose of 36 to 40 gray to the prostate. We've had great results. There was a lot of excitement on MR-Linac after the publication of the Mirage trial out of UCLA. Their group basically showed that with MRI-guided SBRT, so same doses in a prospective trial, they found less acute toxicities with MR-guided radiation, presumably because you're using a smaller margin, because you can actually account for the prostate motion during treatment on the MR-guided machine as opposed to a standard photon unit. So that created a lot of buzz, but at the end of the day, I think what's going to push the needle and really make MR-Linac, the MR-Linac believers to really say that this is a superior mode of treatment would be if the late toxicities are improved. So I think that just requires longer follow-up on the Mirage trial and other trials that are ongoing.
All right. Yeah. That's amazing. I mean, I think there's so many opportunities and options. I think it's very, as you rightly pointed out, it's patient-centric. You find the right treatment that fits best for your patient's needs. And that is, I think, is a very important aspect of the care delivery that is being provided for patients at Miami Cancer Institute. So maybe moving forward now in the advanced cancer setting, beyond localized cancer, beyond biochemical relapse, unfortunately, there are a percentage of patients who eventually develop metastatic disease, which becomes resistant. We have several new treatment strategies now, and there is this rapidly evolving field called theranostics, which I guess, again, talks volumes about multidisciplinary approach, how well we can coordinate to give our patients the best care. Maybe you can start about what is your opinion about theranostics, and maybe we can dive into our clinical trials with that.
Right. So classically, in terms of, the role of radiation in prostate cancer, it's been limited primarily to patients with curative cases. So low risk, intermediate risk, high risk patients that do not have metastases. And the field was really biased towards external beam radiation because of that. And as you pointed out, the game changer has now been the introduction of radiopharmaceuticals, targeted radiopharmaceuticals to be more specific. And the real trial that pushed the needle on this was the VISION study that was completed in Europe, which basically showed that for those patients who were at end-of-line therapy, meaning they've exhausted all the anti-androgen therapy, hormonal therapy, all the targeted agents, and chemotherapy, then those patients were examined in a clinical trial where they were given standard of care or standard of care plus Pluvicto, which is a lutetium-177 based treatment. And what they found was that those patients who received Pluvicto actually had a better survival, and in addition to that, improved quality of life. But I always tell people this is not a cure. It's just another systemic therapy in addition to the systemic therapies that they've already been receiving with their medical oncologist. But it's nice to now finally have an option available for these patients who are advancing in terms of their cancer after even chemotherapy.
Yep, you're right. This is a valuable option, especially compared to chemotherapy. It's well tolerated. That is very key for these patients because who are generally elderly with widespread disease and a treatment which can be well handled. So again, as doing a deep dive into this topic, we want to improvise on, as you rightly pointed out, it helps, but not long term. The durability is not there. So we are glad to have, opportunity to open clinical trials. And in fact, there is a trial which we have at Miami Cancer Institute. It's called LUNAR, which is actually looking at the synergy between lutetium-177 with a PARP inhibitor called niraparib. It is exciting because both drugs have a potential synergistic mechanism. Both affect the DNA of the cancer. One damages the DNA and the other one prevents the repair. So we are very glad to be one of the only institutions actually in US to have the combination of a PARP inhibitor and lutetium in advanced setting. I think this has a potential to move the needle to see if we can help more patients and also help them achieve a durable response with the theranostic therapy. Obviously, it's a first-in-human study, so we are very careful. We want to make sure it's safe, doesn't cause any side effects for patients. But I think in the realm, I think the next decade, we will see theranostics to be spoken about more and more. And not only about lutetium-177, I think there's a high probability to get other radiopharmaceuticals, as you pointed out, potentially actinium-225, thorium, and maybe iodine-based and some other copper-based theranostics, which we could provide for patients, which are reasonably well tolerated and adds to their options. And moving forward, I also actually want to, in the introduction, we spoke about the combination of PARP inhibitors and androgen receptor pathway inhibitors. So beyond targeting the cancer-expressing PSMA, we can also target the cancer genomic profile. Patients with prostate cancer are known to have mismatch repair deficiency or DNA repair deficiency. And now there are about up to 25% of patients who have BRCA1, 2, ATM, RAD51. These are all different genes which help repair, and there are drugs which can block them. And we have at least 4 different drug combinations which work for them. So there is niraparib, olaparib, there's talazoparib, and and rucaparib. These are the options which we can use for our patients. So this adds to their treatment armamentarium. And if they have something called MSI high, we have the option to use pembrolizumab. Now, moving forward, there's another trial which I actually wanted to briefly touch upon. We, as a part of NRG, we have a trial called NRG GU009. Can you talk about that trial and how it is helping our patients?
Right. So we're excited to, at Miami Cancer Institute, be a voting member of NRG. NRG Oncology is a national organization, NIH funded, promoting research and larger clinical studies across the United States. And basically, we are collaborating with them on one of their bigger studies, which is GU009. That's a study specific for high-risk prostate patients. And what it's really trying to do is personalize care. And the way it's doing that is looking at the genomic analysis of the tumors. So in addition to the classical features that we use to risk stratify high-risk patients, right? Gleason score, PSA, clinical stage, we are now leveraging the Decipher test. And we basically are using this test to look at gene expression. It's a validated test that's already being used, but specifically in this trial, we're looking to distinguish high risk from very high risk. So those patients who are just high risk, the question is, can we de-escalate therapy, in particular systemic hormonal therapy? And so those patients are randomized if they have a low Decipher score to 1 year of ADT versus the standard 18 months. If, however, they have a high Decipher score, then we're looking at potentially dose escalation because we're concerned this is an aggressive tumor. So those patients are getting standard of care versus standard of care plus an additional drug, ipilimumab. So I think, it's an exciting study. I'm very excited that we are able to offer it to our patients at Miami Cancer Institute. And it just highlights, again, how we're trying to personalize care. And just piggybacking also on the point you made earlier about doublet therapy and combination therapies, I think this is very important. Combination therapies are routinely used in a lot of cancers, FOLFOX and gastrointestinal cancer, ABBD and lymphomas, et cetera. And this combination could be very, very synergistic. So I think we are very excited to have the LUNAR study at Miami Cancer Institute. And in addition to that, we also are exploring possibilities of layering on focal therapy to our systemic agents. So there was a lot of movement in the last few years in terms of adding on SBRT, which is focused high-dose radiation treatment to metastatic lesions after the publication of the Sabre Comet study. And in addition to that, for prostate specifically, the Oriole study, which was out of Hopkins, basically showed that you can target PSMA avid and osseous lesions and actually increase the time interval that you could stay on a systemic agent or without a systemic agent.
Right. I think it's exciting time right now because we have so many options. And the most key aspect for a patient is, we have a multidisciplinary care. It's a patient-centric where we are focused on the patient, but different modalities. It's medical oncology, radiation oncology, and our urology oncology colleagues. We all work together so that we give our patients at Miami Cancer Institute the best care they can receive. And at the same time, They get to see all the providers so that they can understand different options, and then be it genetic driven, imaging driven, or disciplinary driven, we are able to provide them the best care they deserve. So moving forward, one other important aspect, maybe a brief aspect I would like to touch upon is genetic testing. People currently, we are not treating patients just based on the name of prostate cancer. We are trying to do a deep dive into their genetic makeup. Any patient who has metastatic prostate cancer, it's critical for us to obtain their genetic makeup, to understand what kind of mutations are driving. And we are tailoring therapy based on genomic testing. And other critical point I would like to add is germline genetic testing. Not only testing the tumor, but we are actually testing the patients to see if they're born with those abnormal BRCA1, BRCA2 mutations, because you'll be surprised. It's quite a common mutation. In about 2 to 5% of patients with prostate cancer, we do find that. And in the last 4 to 5 years, all the guidelines have been revised, especially from ASCO, NCCN, and now it's a routine practice for people whoever presents with high-risk prostate cancer, metastatic prostate cancer. They need to be checked for germline mutations to see if they're born with, so that this helps their family, the first generation of family members, to see if they are the carriers of those mutations. So again, to talk about the multidisciplinary approach, we do have our medical geneticists who are a part of our team who help us with this testing. So again, it was really, nice chatting with you with all the things which we have, from screening to imaging to novel treatments to clinical trials we have for prostate cancer patients, and more importantly, focusing on multidisciplinary approach so that the patients get their best care. Thank you, Dr. Kaiser, for taking your time and discussing about what we have to offer for patients with prostate cancer at Miami Cancer Institute. It's a great learning opportunity for me as well to learn different tools and techniques what patients can get from radiation oncology team.
Yeah, and thank you again, Dr. Gargi. I agree. I think it was a great discussion. We learned a lot. Hopefully the audience will have a lot of points to think about and to help their patients.
To find out more about the topics covered on the Doc to Doc podcast, please visit physicianresources.baptisthealth.net.